In this video, we are going to talk about the newborn screening for congenital hearing loss. So it used to be that only kids with risk factors were screened, but a lot of these kids with congenital hearing loss actually have normal hearing parents, and a majority of these cases were being missed. So congenital hearing loss manifests around 6 months to 1 year when a child has already developed speech and language delays. So early intervention is crucial. In this video, we are going to review the anatomy of hearing. Notice that it's hearing and not the ear, differentiate among screening methods, and by the end, you will have an idea of how to start making a differential for an abnormal screen. So we should first talk about the audiogram because it's the gold standard for diagnosing hearing loss. From this audiogram, we can appreciate that there's two elements to sound. So there's hearing level, which is measured in decibels and is really volume. You can see where a whisper is versus a shout would be placed. We also have frequency on the x-axis, which is just pitch. So it's like keys on a piano. Now, an audiogram will pick up on all levels of hearing, mild to profound, but it does require a behavioral response and interpretation by an audiologist, and these are not possible in a newborn. So we have other quick screening tools that can pick up on moderate to profound hearing loss. And the two most commonly used methods are called the otoacoustic emissions and automated auditory brainstem response. The otoacoustic emissions will tell us about the health of the cochlea, while the AABR is going to tell us about cranial nerve 8 and the brainstem. So to get a better understanding of these methods, let's look at the anatomy of how we hear. Sound goes into the ear, travels through the external auditory canal, which vibrates the tympanic membrane, stimulating the ossicles, the malleus, incus, and stapes. Sound energy is then transmitted to the cochlea, which we have unrolled here. It goes through the oval window and causes a ripple in the perilymph. That ripple is transmitted to the endolymph, which is colored hot pink to represent the potassium-rich environment. The hair cells on the basilar membrane then bend, and potassium from the endolymph leaks in, causing depolarization of those hair cells, which then release neurotransmitters to cranial nerve 8. And this electrical signal now travels to the nucleus in the pons, then up to the brainstem and to the temporal lobe. So in otoacoustic emissions, a microphone is inserted into the ear, and we normally have emissions or sounds from the outer hair cells that travel retrograde out of the ear and are picked up by this microphone. So in the healthy ear, that is normal cochlea, patent middle, and external ear, these emissions should be present. False positives can occur if a patient has otitis media or amniotic fluid in the middle ear. We also have the automated auditory brainstem response, which is just like an EEG. A bunch of clicks are delivered in the ear, and the leads pick up waveforms that correspond to the neurons in cranial nerve 8 and the brainstem and tells us if they're working. The automated part of this word just comes from the fact that the end result is either going to be a pass or fail and doesn't require interpretation by a specialist. Now, most cases of congenital hearing loss affect the cochlea, so let's zoom into this area. We have the basilar membrane, and on either side we have the endolymph that is potassium-rich in contrast to the perilymph. On the basilar membrane, we have two types of hair cells. We have inner hair cells, which transmit sound to the auditory nerve, and outer hair cells, which act as amplifiers for the inner hair cells. So if the inner hair cells are our electric guitar, the outer hair cells are the amp. All of these parts of the cochlea are connected by potassium recycling. So as sound goes through the ear, a ripple is formed in the endolymph. The stereocilia of the hair cells will bend and potassium will enter the hair cells, with the end result being that the hair cells release neurotransmitters to cranial nerve 8. But potassium needs to get back into the endolymph. So we have these cells here that are connected by gap junctions formed with the protein connexin 26, which I promise will be relevant later, that pump potassium back into the endolymph. So damage any of these cells and you will get a sensory neural hearing loss. Now, in coming up with our differential for congenital hearing loss, it's surprising that 50% of causes are actually genetic, and 70% of these genetic causes are non-syndromic, meaning they occur isolated. And most of them are autosomal recessive, so kids could very well have parents with normal hearing. The most common cause of this is a defunct connexin 26 protein from a gap junction beta 2 mutation. 30% of causes are syndromic, meaning they occur with symptoms. And I've listed a few interesting syndromes to consider. So Usher syndrome can occur with retinitis pigmentosa. Actually, about half the blind and deaf population in the U.S. have Usher syndrome. We also have Jervell-Lange-Nielsen syndrome. Here, the potassium pumps in the hair cells is affected, as well as the potassium pump in the cardiac cells, which leads to a prolonged QT interval. Pendred syndrome can present with sensory neural hearing loss and a euthyroid goiter. Waardenburg syndrome is an interesting one because there's pigmentation defects that occur with the sensory neural hearing loss. So patients may have brilliant blue eyes or a white patch of hair above their forehead. Lastly, we have Alport syndrome, in which the patient has renal abnormalities. 25% of our cases are unknown etiology, and the other 25% are acquired. So of these causes that are listed, we see that CMV and maternal rubella are part of our torch infections. We also have meningitis as well as aminoglycosides, which are ototoxic. So if a newborn was treated with gentamicin for sepsis, you can suspect this. Let's do 2 quick cases to drive home some points. So in the first case, a newborn is found to have a normal OAE but abnormal AABR. What is the lesion? So if we think of the anatomy of a normal OAE, this means that we have a healthy cochlea and a patent middle and external ear. So the lesion must be retrocochlear. So 2 diagnoses come to mind. They are acoustic neurofibroma, which affects cranial nerve 8 and is seen bilaterally, neurofibromatosis 2, and auditory neuropathy spectrum disorder. This is a group of disorders that affect the auditory nerve, hence it's a neuropathy, so that sound is not properly transmitted from the cochlea to the nerve. In her second case, a newborn passes her hearing screen, but at age 7, her mom brings her in complaining she doesn't seem to hear me when I call her name. So it's important to note that the hearing screen is not perfect and we can get false negatives. Some causes of these are that we might have a mild hearing loss. So these screening tests, the OAE and ABR, are going to detect moderate to profound and miss that mild. We can also have progressive hearing loss. So CMV is known to be delayed in onset and to be progressive. We should also look for central reasons why a child is not hearing. So central auditory processing disorder is a disorder where the brain's function to localize sound and block out background noise is not working. So we'll get a normal otoacoustic emissions, the ABR can be normal, and we actually have a normal audiogram. So it's important to realize that this is not hearing loss and it's really a dysfunction in cortical processing. So that sums up congenital hearing loss in the newborn screening, and I hope you enjoyed this video. Thanks for watching.